Right, good morning and welcome to the AANMC webinar, Naturopathic Approaches to IBS and a Healthy Gut. With us today, we have Dr. Joseph Vazquez. Dr. Vazquez joins us from the National University of Health Sciences, where he's an assistant professor of clinical sciences and attending clinician at their health center. He specializes in epigenetic considerations, treatment protocols for small intestinal bacterial overgrowth, naturopathic care for weight management, athletic training, and Lyme disease. He's also conducted research in Lyme disease and published work as well. Dr. Vazquez participates in the AANMC's Council of Chief Academic and Clinical Officers, and I'm very, very happy to have him with us today. Before we get going, I just want to go through a little bit of housekeeping. So thank you all for joining us today. There is a Q&A box if you have your Zoom open. It won't work if you're on by phone. But there's a Q&A box for any questions that you have during the course of the webinar. Please do not use the chat box. Please use the Q&A for any questions, because I can't be checking both places and make sure I've got everything going on. So I appreciate that. And this webinar will also be recorded, and we can send it out if there's something that you didn't quite catch or you want to listen to again. So with that, thank you very much for joining, and thank you, Dr. Vazquez, for joining us this morning. I'm going to make my face go away and go on mute, but I'll be here listening. Thank you very much.
All right. Well, thank you for having me. It's quite a pleasure, especially to speak in regards to this topic, irritable bowel syndrome, and the importance of gut health and overall comprehensive care. So let's go ahead and get started here. So I do want to share a little information about myself, my background. I was a chemistry undergrad major at Austin Peay State University, a very small Division I college in Tennessee, and I had always known that I wanted to go into medicine. That was always my drive, always my passion. I always wanted to be in that field and interact with patients and just make people feel better in that regards. A little funny story, my father was actually a naturopathic physician, and which meant that when I was a teenager, I was going to grow up to be anything but a naturopathic physician, because that's what teenagers do. But as I found my way through college, I found that naturopathic medicine was actually one of the best ways to instill that patient interaction, to make sure that you had a comprehensive intake, a thorough assessment, had the time that you felt was necessary to really find out what was going on, to determine that root cause of disease, and then to essentially create a treatment plan that was individualized to the patient. That's something that they could reasonably do, and it was a personal story, if not a personal trek for them with you and the patient. So I was, like I said, a chemistry major. However, I did a lot of research in microbiology. A lot of research with Borrelia burgdorferi, which is the causative etiology of Lyme disease, and then following with research for novel therapeutics for Lyme disease. A lot of that research ended up being published. I completed my naturopathic medicine training at National University of Health Sciences here in Illinois. And then I also completed a preceptorship in Montana, which is a full scope licensed state as well. So I was practicing PRP, prolotherapy, the full scope, including prescriptive medications as well. And then I found my way back to NUHS after being in private practice for a little bit, because I found that teaching was really one of my passions. I really love the education aspect of medicine, especially the education aspect of your patient encounters. In order for a patient to truly be compliant with the patient plan, they need to understand why you're doing certain things. And I feel that naturopathic medicine really lends itself towards that pattern or that model, if you will. And I felt very, very passionate about it. So I teach here at NUHS. I'm also an attending clinician. So I work with interns, with patients, which I feel is a very great opportunity to teach them didactically and then follow through to see how they actually apply it with patient care. Personally, I do a lot of extracurriculars. I'm still doing a lot of research trying to stay healthy during these times, trying to exercise with my beautiful wife and my two kids. Um, and we're trucking along just like I know everyone else is. And so we're doing our best, that's for sure.
So, Dr. Vazquez, thank you so much. Before we go on to the rest of it, the lecture today and the webinar, I have put up just a quick poll to find out who's viewing us and who's in the webinar today. So if you'd be able to fill out this poll for us, that would be awesome. And as Dr. Vazquez alluded to, these are not normal times. And so if there are any additional questions that you have related to schooling, naturopathic medicine, anything moving forward, please email us privately and we'll be happy to help you on your way. Okay, thanks, Dr. Vazquez.
Thank you. So today we're going to be talking about irritable bowel syndrome, the diagnosis behind it, and the standard treatment. Both conventional and naturopathic will find that there's a lot of crossover. We're going to talk about how GI health really attributes or contributes to your overall health. And I always tell my students, in order to really appreciate how vital something is, it has to go wrong. And I believe that IBS is a great condition to really appreciate how GI health is so valuable to your overall health. We'll talk a little bit about nutrition and lifestyle approaches to improving gut health, especially specific to IBS. And we'll end with a little patient case study of a patient that I saw with IBS. So IBS is actually quite prevalent. It's a growing diagnosis, if you will. We're looking at about 10 to 20% of the world population that can be actually diagnosed with IBS. Unfortunately, of those 10 to 20% who have IBS, only about 30% actually seek medical care. And so a lot of us can familiarize or know someone who is suffering or has suffered from some kind of GI issue, whether it's distension, diarrhea, constipation, something like that. But when it becomes chronic and there's no true underlying cause of the disease, it's probably IBS or lending itself towards IBS, and it really needs some thorough investigation from a physician or practitioner. What is interesting about irritable bowel syndrome is that it's truly a functional disorder. And what we mean by that is that, quite honestly, we don't really know what causes irritable bowel syndrome. There are a lot of theories out there in regards to what could be causing it, but we know very well, are very familiar with the symptoms that present. And so when we say functional disorder, we can identify inflammatory pathways that are lending themselves to it. We can identify a lot of HPA axis pathways, hypothalamus, pituitary, adrenal, contributions to that pathology. We've noted alterations in the GI biome, so essentially the microflora. A lot of times when there's dysregulation there, we can see symptoms of IBS. And so that's one of the proposed theories of causes for IBS. And then finally, there can be a lot of intestinal permeability and or enteric infection. So essentially actual infection of that mucosal lining secondary to what we tend to call leaky gut. And so a lot of times IBS is a multitude of all of these things happening all at once. And that's what really contributes to the diagnosis and what can be going wrong there. And I had mentioned to previously, a lot of these symptoms, we see it quite often when it comes to GI disorders. But with IBS, you see a very unique pattern of consistent here, which we'll talk about through the Rome 3 criteria. But a lot of patients with irritable bowel syndrome, they're going to present with that abdominal pain. They're going to present with altered bowel habits. And what we mean by that is you're going to the bathroom more often, less often than you normally will. Abdominal distension, mucorrhea, when we're seeing mucus in the actual stool, dyspepsia, nausea, vomiting, dyspareunia even. Now, dyspareunia is essentially pain with intercourse, abnormal, irregular pain with intercourse. And it's interesting because we see a lot of these extra GI symptoms associated with IBS. And we'll talk a little bit in regards to how that plays a role and how that's very unique to IBS. Now, I said in order to truly diagnose IBS, we use this Rome-3 criteria. For many years, irritable bowel syndrome used to be a diagnosis of exclusion. What that meant was we needed to assess you for almost every single GI disorder before we said, well, it's none of these things, then it's IBS. Now we can just use the Rome-3 criteria, which basically says that the patient is experiencing symptoms for 3 days for the past 3 months that's relieved by defecation, that has increase in stool frequency, or there's some kind of change in the quality of the stool. It's more runny or it's harder, something like that. And that's how we truly classify IBS nowadays. Now, that the consideration that we need to talk about is that there are still conditions that we have to rule out, very serious conditions, including your IBDs. And these are your irritable bowel diseases. And they include celiac disease, ulcerative colitis, Crohn's, and so forth. And so we need to be able to assess these things, be able to rule these things out before we can move forward with the diagnosis of IBS. A lot of times there is significant family history of having these IBDs as well. So if there is a family history, then it's very suspect that the patient more likely has an IBD as opposed to IBS. Now, IBS, we see there are a lot of different symptoms here, but primarily what we tend to see is diarrhea, constipation, or a mix of the two. And so we have subclassifications. We have IBS-C for constipation, IBS-D for diarrhea, and IBS-M, which stands for mixed, of both diarrhea and constipation symptoms, which alternate, if you will. There is also an IBS-A, which stands for alternating, which can be used simultaneously with IBS-M, the mixed. Now, when it comes to treatment, we need to address both the symptoms and the cause. Now, I had stated previously the pathophysiology, which basically means what is causing this disease, is a little unknown. But we do know that certain pathways are engaged that we need to address, inflammatory pathways being one of them. One proposed theory is that IBS is actually a collection of microinflammation. So we have a lot of inflammatory processes, if you will, happening throughout the gut, and it's causing the gut to spasm. It's causing the gut to essentially secrete some more fluids, either causing constipation or causing diarrhea, respectively there. And so in order for us to truly help the patient, we need to address that. At the end of the day, and this is something that I truly admire and appreciate about naturopathic medicine, not only do we address the root cause, but because our treatment plans are so individualized and are very unique to the patient, we need to make sure that they're living a good quality of life as well. So a lot of times, even though we're treating and addressing the root cause, we're going to have to address symptoms as well. Many patients who are dealing with IBS, especially for chronic times, years, or decades even, they're just looking for some kind of relief in this moment. And
Dr.
a lot of times, yes, ma'am.
Would you be able to discuss the Rome criteria?
Sure. I did in brief. So the Rome-3 criteria essentially states that you are having abdominal pain or discomfort for 3 days of the month for at least 3 months. And then you either have 2 or more of the symptoms of either symptoms relieved by defecation, increased bowel movements or changes in bowel movements, whether increased or decreased, and or change in the actual formation of the stool. So as long as you have 2 of those things, in addition to the distension and abdominal pain 3 times out of the month for the past 3 months, that's the Rome-3 criteria that leads to the diagnosis of IBS.
I think someone was asking about Rome-4.
Rome-4 is a more advanced, now there are certain associations that use Rome-4 for classification, but standard of care right now uses Rome-3. There are other algorithms, if you will, to classify IBS as well. There are times where diarrhea and constipation don't necessarily have to be present. It's just the distension and the pain as well. But standard of care right now dictates that the Rhone 3 criteria is what we should be applying. I hope that addresses
Thank you so much. Yep,
yeah.
thanks.
So moving forward with treatment, I had mentioned before in symptoms that we see a lot of extra gastrointestinal symptoms. We see a lot of fatigue, we see a lot of muscle aches, if you will. But one very, very unique correlation is this idea of psychosomaticism, where we have a lot of psychiatric or mental emotional induced symptomology. Now, you see this a lot, not only in IBS, but in IBDs as well, other GI diseases and disorders. In fact, we see this in patients who are asymptomatic, we know very well. For those of you who are currently taking courses right now, those butterflies that you get in your stomach when you're thinking about taking an exam, when you're about to start, essentially that's the stress, that's the anxiety, if you will, that's your mental aptitude inducing GI symptoms. So you could argue that it's a little bit of distension. Now we see that with celiac disease, we see that with Crohn's and ulcerative colitis. However, almost 60% of patients with IBS have a well-documented link between those psychosomatic induced symptoms. So a lot of times IBS patients tend to be very stressed, very anxious, and if they aren't, it only takes very little emotional changes for them to induce GI symptoms. So a lot of times when you're doing an intake, you'll find that patients who don't handle stress well tend to be very, very symptomatic. And if you're able to investigate that, play Sherlock Holmes, if you will, I always tell my students, to break down the case and recognize that, hey, when this patient is very, very stressed, they tend to be extremely symptomatic, then it's likely guiding you towards that consideration and or diagnosis of IBS. So not only do we have to address the microinflammation, like I had noted, but there has to be some element of counseling there as well, whether it's cognitive behavioral therapy, biofeedback, something of that sort, because it's a huge component to manage symptoms in the meantime as well. The next bullet here is the introduction of soluble fiber. Now, everyone seems to be on the same page, and by everyone I mean all healthcare professionals seem to be on the same page that the introduction of adequate amounts of soluble fiber into the diet tends to help relieve symptoms in IBS patients. There are some ideas that it helps to essentially allow for a more regular transit time, allow for more regular bowel movements, but we tend to see a lot of good effects by introducing soluble fiber. If we were to introduce insoluble fibers, so fibers that aren't really broken down so well in the GI tract, you're going to see an increase of symptoms. So it's very important to introduce soluble fibers. So we're talking about flax, we're talking about those green leafy vegetables as well, those root vegetables, those things are really going to help. The third bullet point here we note is restoring the microflora. We tend to see a lot of issues with the actual flora of the gut in patients with IBS. What we can't say for sure is if the dysregulation of microflora was the causative feature that led to IBS, or if the IBS and the pathology of IBS, the physiology of IBS, led to the dysregulation of the flora. Either way, you kind of have this catch-22 cyclical process occurring where a lot of times you have dysregulation of the microflora. So it's very important that we address that and essentially restore the flora. When it comes to overall gut health, not only for IBS, but anyone who needs it in regards to GI health, we definitely need to address lifestyle and nutrition. Now, both of these things encompass changes in diet or looking at the diet to see what is it that the patient is eating, and what regulations, what corrections are needed in order for the patient to improve in their symptoms. We find that dietary recommendations, at least personally, especially through naturopathic medicine, need to be very individualized. Different people respond to different foods. It's just plain and simple. It's, in my opinion, it's a little lackluster to say that a certain food is bad for everybody, and another food is good for everyone, as everybody as well. But we really need to stop and assess the diet for that individual. A very classic example is gluten. A lot of patients are reactive to gluten, and some patients are not. Take me, for example. I am a very proud naturopathic physician, but if I had to give up a cake, a slice of cake, a donut every now and then, oh, you wouldn't see me here right now. So the big thing to keep in mind is that each dietary plan needs to be individualized to the patient, and we need to identify a lot of food sensitivities, food allergies, and so forth, eliminate those foods, and produce a whole foods diet that is appropriate for the patient. And if the patient improves symptomatically, we may consider reintroducing some of those foods to see if that patient is actually truly reactive to it. Another aspect of lifestyle that we tend to forget about or disregard, especially for dietary considerations, is actually having a routine schedule through the day, managing stress, managing life, if you will. And that's no more true in these trying times with our current situation. Exercising regularly on a daily basis is going to help essentially not only stimulate metabolism, but also stimulate nervous system conduction that actually promotes bowel movements and proper metabolism and GI absorption. So all of these things we have to consider when treating our patients. So with my patient case study, one of the things that was very unique about this patient was that she presented textbook. And I always tell my students that, we talk about textbook presentation of diseases, and then we go out into the real world and we find that a lot of our patients are not textbook. That's just how it is. There are elements that make us think a certain disease, but there are other elements that make us think another disease or another differential diagnosis. And so we have to be very good diagnosticians, but we don't stop there. We have to make sure we assess. We have to make sure that we're providing appropriate management plans as well. Excuse me. So we have this 45-year-old female patient, and she presented with chronic abdominal distension, intermittent diarrhea, and constipation, and overall fatigue. And the unique part of the story was that her chief complaint was really the fatigue. She didn't say that the GI issues or abdominal distension were really impacting her life. It was really the fatigue. She wanted to be out and going. She wanted to have the energy to complete her daily tasks. And so when we did a thorough history and we assessed her using the Rome 3 criteria, we assessed her family medical history. There was no history of irritable bowel diseases, no celiac, no Crohn's, no ulcerative colitis, nothing of that sort. Then we suspected that this was probably an issue of IBS, a mixed type disorder, since she was presenting both with the diarrhea and the constipation that was cycling actually every month. 1 month would be diarrhea, 1 month would be constipation. And this is something that she had been dealing with for over 15 years. So it was pretty chronic. It was something that was obviously bothering her for quite some time. However, what I think is very interesting is that this woman who's 45 essentially became symptomatic at age 30. Up to age 30, she denied any issues of GI motility, any issues of bowel movements, no distension, nothing like that. She said she was relatively healthy leading up to that point when she turned 30. And this is something that is quite often missed when we don't do a thorough assessment and try to get all the history that's necessary for us to make an appropriate diagnosis. When we got more history and we did this comprehensive intake to really understand who she was as a person, what impacted her life and so forth, we found that she had significant emotional lability. And what we mean by this was she tended to stress very much. She tended to stress eat. She tended to be very nervous and anxious. She tended to cry a lot. She tended to get very angry for certain times. And this really stands out. And I went off, stood on the ledge and said, yes, this is actually very typical of an IBS patient, textbook, if you will, because like I noted previously, there are a lot of these psychosomatic presentations, especially in the IBS population. So when we wanted to come up with the treatment plan, we wanted to, again, individualize it to her and to break it down in parts. We could have very well said, okay, change your diet, change your life, get some counseling, don't eat these foods, only eat these foods, and then come back in 3 months and see how you're doing. We all know very well that this is very difficult to do. In fact, a lot of us in stay-at-home orders or in quarantine, we say, this week I'm going to exercise and eat healthy, and it lasts about 2 days if we're lucky. And so all these radical changes, if you will, are very difficult to do all at once. I'm not saying it's impossible. Some patients can do it, but a lot of patients need plans that are stepwise. And again, like I noted before, that are unique and individualized to what he or she is capable of doing in that moment in time.
Dr.
So,
Vazquez,
yes, ma'am.
would you be able to expand upon IDA?
Oh, yes. Iron deficiency anemia. So we found that she was also anemic, and it was most likely due to poor iron absorption. When we have a lot of GI issues like IBS, like we noted, we have this microinflammation that's occurring. We have this breakdown in mucosal integrity, essentially the leaky gut consideration. And so when the GI mucosa is broken down in such a way, we're not absorbing a lot of the minerals and the nutrients. And so a patient with IBS could actually be eating a very good diet and still present symptomatically with fatigue, with nutrient deficiencies and so forth, because that food is not being digested properly and it's not being absorbed adequately, at least not adequate to maintain appropriate levels. And so we noted with this patient, she was also anemic, specific to iron deficiency. And we alluded to the fact that it was most likely due to her poor ability to actually absorb fiber as opposed to her poor intake of fiber. Admittedly, it could have been a combination of the two, but we went more towards the absorption aspect of it, and it's something that we would address when we're addressing the inflammation of the gut mucosa. So moving on here, the first aspect was to address, like I said, that mucosal regeneration and to immediately start the counseling. Now, naturopathic counseling is within our scope. We work with a lot of other healthcare providers if we feel that it is beyond our primary care scope, or if it's something that is quite individualized, or something that we don't feel comfortable addressing. With this patient, we found that she was very open to communicating with me personally. And so she was coming in weekly for constitutional hydrotherapy treatments to essentially regulate nervous function. And during those times, we would have conversations about how she was handling stress. What was it that made her so stressful? What was it that made her so emotional, so angry, so sad sometimes? And we made a lot of progressive work by having those conversations on a weekly basis. And so we kept it very simple. We addressed that mucosal regeneration, which we can do with a lot of different types of therapies, if you will. We can go botanical routes for a class of botanicals that are called demulcents. They essentially create a nice coating of the mucosa and calm down that inflammation. We can give a lot of anti-inflammatories, including bromelain, quercetin, curcumin, things of that sort as well. And a very popular choice, one of my preferences, glutamine. Glutamine, an amino acid, is a nice precursor towards restoring GI mucosa. There are always side effects and caveats towards these treatments. Glutamine, for example, is easily converted to glutamate, which is an excitatory neurotransmitter. And so a lot of times that could actually cause upheavals of her emotional lability. And so we were very careful to start at a very low dose of glutamine as well. At 1 month, she noted that her bowel movements had slightly improved. She was, when she saw us, she was presenting with diarrhea, going to the bathroom around 4 to 5 times per day. At this point, she was going consistently about 3 times per day. She noticed that she was handling stress a little bit better. Now, it wasn't a miraculous turnaround, but it was showing that there was progression going towards there. At 2 months, she was reporting 2 bowel movements per day, and at this time, her bowel movements were formed. Essentially, a number 4 on the Bristol stool scale. I don't have it on hand right now, but essentially, this is what we're looking for in our stool formation: a long, formed brown color. At that point, we thought it was appropriate to then essentially give her some supplemental nutrition. Now that we felt that her GI mucosa had been restored to a point where there was going to be adequate absorption. So we decided to supplement with supplemental iron, vitamin C, and vitamin E. The iron form that we gave her was of desiccated liver. It absorbs much better, especially when transferrin and those transport proteins are low. We continued with those targeted GI therapies with helping the GI mucosa. And then eventually we discontinued them because, again, we don't want our patients to be dependent on these therapies. We want to restore them to natural health with as little intervention as possible. At about 6 months, the patient reported that her GI health was well regulated. There were no ups, there were no downs. And she noticed that she was having better relationships. More specifically, she had a very sour relationship with her sister. She had reached out to her sister and they were talking more. Same goes with her mother. She had reached out, she was talking with her more as well at that point. And so in 6 months, we had this significant turnaround from what looked to be like 15 years of this symptomatic presentation. And this is pretty unique to this patient because a lot of times when you're dealing with symptoms of that chronicity, it usually takes a little time for this to actually help. A lot of my other IBS patients, 10 years, 5 years of symptoms, we're looking at about a year, if not longer, to actually regulate everything and get them back on track. With this patient, we didn't elect to do any microflora regeneration, but it is something to always keep in mind. Typically, we address it as if it's a small intestinal bacterial overgrowth condition where we're prescribing a low FODMAPs diet, and that stands for fermentable oligosaccharide diet. We're reducing those amount of sugars that ferment and can feed overgrowth of bacteria. We reduce those foods, and we essentially try to give some kind of either antibiotic or antimicrobial to essentially kill all the microflora and then restore it using probiotic therapy. I feel like this is a great example, this case in particular, of doing a comprehensive assessment. We would never have really picked up on the fact that she had this increased stress only at age 30, which later she told us was when she actually moved out on her own and she cut off communications with her sister and with her mother. It was around that time that the symptoms actually started, and they started progressively and got a little bit worse. With the comprehensive assessment, we were able to identify the emotional lability, the stress, the anger, if you will. And again, that's really what's beautiful about naturopathic medicine, is being to address all of those things. And same goes towards the management as well. With the comprehensive management, it was very, very interesting to note that we started slow and we addressed multiple factors. It was a multifactorial approach, if you will, and it really helped lead towards the progression towards health for this individual patient. And that tends to be very true and very pattern-like for a lot of the patients that we see in practice. And I always emphasize this to my students and anyone asking about naturopathic medicine. Naturopathic medicine is really true primary care, where we have the ability to assess, to manage our patients and create a plan that's individualized to them with a very, very large scope of practice. There are patients where I've prescribed rifaximin, a very popular antibiotic used for traveler's diarrhea and approved for IBS to essentially induce that low FODMAPs diet. When it comes to naturopathic medicine, I feel it's important to note that we are not against any kind of other conventional therapies. We're not against pharmaceuticals. We're not against surgeries. It's more of what is going to be best for you as a patient in this moment in time. Can we address your condition? Can we address you as an individual using lower level management? Or is this something that's going to require anticholinergic medication like Bentyl or hyoscyamine? Again, I've had patients where we've had to use those medications. Or something like loperamide to stop the diarrhea because they were just going too much. All of these things, again, it's individualized to the patient. And it's one of the things that I really appreciate about naturopathic medicine is that I am afforded this large scope to practice in a way that I feel is going to make the patient better and provide great quality of life for that patient. So I hope you got a little introductory information, some foundational knowledge for IBS, gut health, and how naturopathic medicine can help for these conditions. Me in particular, I plan on continuing with my efforts in higher education. I really love talking about these things. I really love educating students, future doctors, and prospective students and patients about what naturopathic medicine is, what we can do for our patients. To prospective students out there, I wish that I had known all of this a lot sooner. I wish that my drive for medicine wasn't just geared towards either osteopathic or allopathic. It's important to know that you have these three options: allopathic, osteopathic, naturopathic medicine. And I feel naturopathic medicine really lends itself towards true primary care and really affords you an opportunity to use a lot of modalities, whether it's pharmaceuticals, whether it's botanicals, whether it's homeopathy. Again, whatever is going to work best for the patient and whatever you feel most comfortable with. So that does it for me. I'm ready for any questions that you may have, and I'll try to provide the best answers that I can.
Awesome. Thank you so very much. Would you be able to go to the next slide? I just want to announce the upcoming events really quickly.
Sure.
Thank you. So AANMC, as you know, hosts events every month. We have allergies coming up in May and integrative cancer care. And if you go to the AANMC events page as well, we are participating in virtual fairs today for diverse students, students from diverse backgrounds. And we're also participating in high school virtual fairs as well this week and next month. So if any of those sound like you, hope that you will join us in those events, and please make sure that you're checking them out because we do a lot of these every month. So thank you very much. So with that, I'm going to start. We've gotten a bunch of questions, Dr. Vazquez, so if you can try and keep the answers tight so we can get to the most, that would be awesome.
Sure.
Fabulous. Okay, so let's see. Your patient that you discussed had fatigue. There was a question about fatigue related to bowel movements. Can you discuss a little bit of the mechanism behind why there's fatigue? Now, I know in the patient you discussed the fatigue possibly was due to the iron deficiency, but can you discuss the fatigue with the bowel movement?
Sure. So with bowel movements, especially if they're irregular or either with constipation or with diarrhea, we essentially get irregular stimulation of sympathetic and parasympathetic stimulation of the central nervous system. If either one of those parts of the systems are taxed, it can easily lead towards fatigue. When you lose that regularity of bowel movements throughout the day, your metabolism can be thrown off as well, your overall cellular metabolism. And so a lot of times patients tend to find themselves fatigued because the metabolism is being thrown for a loop. It's either under metabolized or it's being hyper metabolized, causing fatigue from being distressed in that regards, or there's just not enough metabolism to allow for enough energy production to allow you to get through the day.
Thank you. Can you discuss family history with IBD, and is it just immediate family? What types of history is important in kind of sussing out the diagnosis?
Sure. So with family history, we're looking at immediate family. We're looking at mother, father, siblings, grandparents. We also do assess for secondary family members, cousins, uncles, aunts, and so forth. But when we assess family history, we tend to generally ask, so how's your mother's health? How's your father's health? How are your siblings' health? And then we ask, are there any significant health considerations that you're aware of in any of your secondary family members like cousins, uncles, and aunts? We don't want to find ourselves wasting time and losing time asking about every single member. But we find that within that direct family is really where that family history link is very significant for IBDs.
Thank you. Can you discuss the theory about leaky gut and IBS and IBD?
Sure. So the leaky gut, or essentially the lack of intestinal integrity leading to permeability, is not specific to IBS. We see this as a component for a lot of other GI issues. And really what's happening is that you're getting gaps, if you will, between mucosal cells of the GI. And what happens is that you have immune system responses to aspects of the foods that you're eating that shouldn't be happening in the first place. This can lead to food sensitivity, and this can lead to essentially a domino effect of chronic inflammation, not only in the GI, but throughout the entire body, leading to symptoms that actually mimic autoimmunity. And so your immune system is triggering these foods because they're being exposed to it when really they should never have been in contact in the first place. This is very, very serious, especially with chronic patients, because a lot of times they end up becoming sensitive to foods that they were not sensitive to before, and we have to gradually reintroduce these foods and kind of retrain the immune system and the GI mucosa so that they're tolerable again.
Thank you. Let's see. There were questions about probiotics and dysbiotic strains associated with IBS, IBD. Can you discuss a little bit about the microflora?
Yeah, so our microflora is a set population of bacteria. Lactobacillus is a very common one that we think of. And so a lot of times this flora either can overgrow or it can be depopulated by a secondary bacteria that shouldn't be there. So essentially exogenous bacteria that we are exposed to in our environment that shouldn't be living in our mucosa. And so we lose this symbiotic relationship. By symbiosis, we mean that we have bacteria living in our gut that lives and benefits off of us, and we live and benefit off of that bacteria. But it has to be a very specific population of bacteria. So when we're introducing microbiotics, or probiotics, if you will, we want to make sure that we're giving probiotics that are a bacteria that tend to live within the gut naturally, and we're not supplementing every single day. We want to introduce it so that it can repopulate on its own. However, with a lot of our SIBO treatment protocols, for example, introduction of low FODMAPs and antibiotics, the goal is to kill all bacteria, both good, but primarily the bad, and make sure that there's no bacteria there so that when we give the probiotic, it becomes much, much more therapeutic and much more effective.
Thank you. Let's see here. There are lots of cases or lots of questions. I'm just trying to shift through all of this. Can you discuss a little bit the testing that was done to rule out any more serious indications, and maybe a little bit of like the algorithm that you went through, as well as if you looked at any stool tests?
Yeah, so those advanced studies are always an option. We didn't actually really go that far with this patient, but it's always a possibility. We can always do stool analysis to assess for certain microbial strains that shouldn't be in the flora. We can always do endoscopy evaluation to check the upper GI mucosa. That's one of the ways we can check for a celiac. We can always do colonoscopy, and that tends to be confirmative for both celiac, ulcerative colitis, and Crohn's as well. I do want to note that when a patient presents with these symptoms of IBS and IBDs, we want to make sure that they don't present with any alarm signs, as we call them, any weight loss, any blood in the stool, things like that, because then it's more likely a more serious condition. With patients over the age of 60, we always need to do a colonoscopy to make sure that we're ruling out any type of malignant disorder like colon cancer, especially if these symptoms are new.
Thank you. Um, so let's see here. Can you discuss a bit on, so there were a couple of questions on the case that you presented. If you could just go into a little bit more detail on mucosal regeneration, the targeted GI therapies, just a little bit more clarity on that.
Sure, sure. So like I noted, I'm a big fan of amino acid therapy, and glutamine was something that we used with this patient. But as I had mentioned, in very, very small dosing. So it's very important to use amino acid and glutamines on an empty stomach. That way there is good exposure, if you will, of the amino acid to the GI mucosa. Other things that we used were botanical demulcents, um, almost, for example, is a good botanical, where essentially you're creating, like I said, this coat in the GI that calms down the inflammation and make sure that certain foods that are eaten do not trigger the GI symptoms that we're seeing here. A lot of it really was geared towards lifestyle modification. We wanted to make sure that this patient was eating 3 scheduled meals per day with a few snacks in between. That way we could really document whether she was reacting to food, how long after food a patient is eating that they become symptomatic, and so forth. If certain foods were causing symptoms more than other foods. Again, when it comes to a management plan, we never have the 100% answer. It really is a process of truly understanding what's happening with the patient and how we can best address and accommodate our treatment plan as symptoms develop and evolve.
Thank you. Can you discuss a bit the relationship with ir irritation and inflammatory bowel and colorectal cancer, as well as polyps and other types of issues that are subsequent sequelae?
Sure. So when we're having microinflammation, and this is more of a cellular biology component, when there's inflammation, you're essentially creating an abnormal extracellular environment. When you create this abnormal extracellular environment, cells have to adapt to it as well. And cells do a pretty good job of adapting to outside stress. However, when there's this chronic abnormal external environment, the internal environment of a cell changes. And long story short, you get this very unique kind of physiologic breakdown of the actual nuclear genetic information. And so a cell is less or more likely to essentially become malignant and stay that way, as opposed to being recognized by the immune system and being discarded. And so this is why we see this increased risk of a lot of these malignant disorders, a lot of these tumor formation, even if they are benign, because the cells cannot necessarily handle that irregular extracellular environment, whether it's acidic, alkalinic, whether it's excess metabolite formation, what be you. Everything really comes down to true cellular physiology.
Thank you. Um, okay. With the patient case that you presented, was there any reason you chose not to go after the small intestinal bowel overgrowth?
Well, the reason we didn't was because one of the things that we wanted to address primarily were her symptoms and her emotional presentation. And we felt like these things were the things that needed to be addressed primarily. We found that when we started off slow, her GI symptoms started improving. And so it was safe to assume that the microflora, even if there were some irregularities there, were not necessarily having a huge impact on this patient. We did introduce foods to her diet that were rich in probiotics, and so we were ensuring that the patient was getting a good population of that beneficial microflora material, bacteria, if you will. And so because she didn't continue with any minor symptoms or major symptoms, it was safe to assume that the flora inevitably became in check during the process without having to specifically address it.
Thank you so much. I was actually just going to ask you about fermented foods. And there was another question that came in regards to intermittent fasting and balancing back out the microflora.
Yeah, so intermittent fasting, there's a lot of literature there in regards to its benefits. For me, especially since I also teach cellular biology, I see intermittent fasting as more as of a metabolic schedule maintenance. By doing this, by intermittent fasting, you're ensuring that certain metabolic pathways are enacted during those periods of fasting and are at prime levels while you're eating as well. That way we have these distinct on and off schedules, metabolic physiologic schedules throughout the day. And that's how I feel intermittent fasting really does play a role. True intermittent fasting doesn't really require that much time of fasting. Very easily you could stop eating at 8 o'clock at night and essentially intermittent fast while you sleep. When it comes to fermented foods, yes, fermented foods are great sources of probiotics. What we have to be careful with, however, is foods that are rich in probiotics, we can introduce too much and we can actually have a lot of adverse GI effects, essentially the symptoms you were trying to get rid of in the first place. And so when that happens, a lot of times it can be because of our therapy as opposed to the pathology that's happening. So we do have to be very careful. And I always ensure and tell my students, and this is how I practice with my patients, we start small in regards to dosing and build ourselves up to a therapeutic dose where we can ensure that they are responding well to it without any adverse effects.
Thank you. Okay. Gosh, I'm trying to get through all these questions. There's one about fiber capsules versus supplementing with dietary fiber.
Yeah, so when it comes to fiber, I am much more a fan of soluble fiber, introducing it into the diet for multiple reasons. I feel like there are more effective therapeutic effect to soluble fiber when you're introducing it to the diet. Fiber is something that should be a component of the diet anyway. Again, at the end of the day, we want our patients to be well managed in regards to their health without having to be dependent on any extra supplemental source or therapeutic source, if you will. So when you introduce it into the diet, you are essentially introducing a habit of having consistent soluble fiber intake in the diet on a regular basis. And so, you know, something as simple as having oatmeal in the morning for breakfast, introducing flax seeds or any kind of berry with seeds in it, psyllium, so forth. All of those things are really going to help with the diet. Now, supplemental fiber does have its benefits, especially if you want a loading dose, if you will. However, it's not something that I recommend to be on for long term. Again, there are much more beneficial therapeutics to soluble fiber intake, dietary fiber intake. You're going to get a lot of other nutrients and minerals from those sources as well.
Thank you. Can you discuss a bit about intravenous therapy and when it may be appropriate?
Sure. It really depends on what kind of therapy you want to introduce. So, for example, If we're doing intravenous enteric nutrition, for example, this is something that it is appropriate, especially if you feel like the oral route has been compromised. So if you feel like if you're going to introduce glutamine, for example, if you're going to introduce vitamin C and iron, or other mineral cofactors, and you feel like the patient just will not absorb adequate amounts by taking these things orally, then intravenous routes is something that is very, very appropriate for patients. I've done it in the past when I was practicing in Montana, and patients tend to respond quite quickly to intravenous routes of nutrition.
Thank you. Okay, let's see here. You had mentioned in your patient case constitutional treatment. Can you discuss a little bit of what that was?
Yeah, so constitutional hydrotherapy is what I had mentioned. It's a hydrotherapy modality where we're alternating hot and cold and using electric stimulation, a TENS unit. And during this process, it's about a 45-minute treatment to an hour. By introducing this contrast hot-cold therapy with the electric stimulation, we tend to essentially stimulate metabolism and calm down nervous stimulation as well. And so it's a very relaxing experience. And at the end of the day, you see benefits in regards to improved immune function, improved metabolic function, things of that sort. So I would say it's not a very targeted therapy, but it's a very beneficial supplemental therapy, especially for our patient in this case with the emotional lability.
Thank you so much. There is a question regarding gallbladder health and the relationship with irritable bowel syndrome.
Okay, so I mean, IBS is not necessarily specific to gallbladder function. However, you can have concomitant pathologies happening at the same time. Gallbladder, what you're going to see with what's released from the gallbladder is very specific to the breakdown of foods that are rich in cholesterol and fats. And so when we have issues with gallbladder, cholecystitis, for example, or cholelithiasis, stones forming and blocking the duct, you see poor issues with the ability to digest fats. And so a lot of times when it's inflamed, you see a lot of symptoms get worse when you're eating fatty foods. When it's blocked, you'll see symptoms get worse when you're eating fatty foods, because those juices, if you will, can't get to the GI. And if you're just not producing enough, you'll find that you're not going to adequately digest these fatty foods, and you're going to see a lot more insoluble or undigested fat in your stool when you're defecating.
Thank you. We have time for just one more question, and I'd actually like to, for those of you who have not gotten your questions answered, please email us at info@aanmc.org. Dr. Vazquez, would you mind just some parting words for prospective students considering this as a career?
Oh, absolutely. Like I'd mentioned, I had my own unique experience, and I will say everyone listening in regards to prospective students, you will have your own unique experiences as well. Naturopathic medicine for me is a evidence-based practice medicine. You have access to a wide range of modalities, like I noted, that are both conventional in practice, alternative in practice, complementary in practice, and you have access to all of it. And when you have access to those tools, you are essentially able to provide adequate primary care experiences to your patient. You are able to refer with confidence when you need to refer. You're able to use intravenous therapy with confidence when you feel it's going to be beneficial. You're not limited to any patient population, if you will. I see MSK patients. You can utilize PRP and prolotherapies. You can utilize a lot of counseling therapies as well. Again, the fact that you're able and have access to all of these scopes of practice, if you will, really empowers you to be a true great primary care physician. And that, for me personally, is what really inspires me to be a proponent of naturopathic medicine. And I hope it does for you too.